Okay, so good morning, everyone. So this is a review for exam number 2, Delta L3. So the content for exam 2 includes both renal and neuro disorders. Okay, so the first topic, which is about kidneys and renal disorders, in which that we covered both CKD and ESRD, chronic kidney disease, and end-stage renal disease. And these are some of the specific, content areas or specific, concepts that I would like, you to review from either from PowerPoint slides, from the book, from other resources. There are also other, educators who have their own YouTube, channels that you can go to, these channels and find the best kind of, uh, videos to watch. Now, for the treatment of chronic or renal disease, which is ESRD, which is a terminal illness, that's the irreversible condition here, is that patients will, this is a very important concept, which is the anemia, is that this is, patients with ESRD, they will be um, diagnosed or they will have the anemia, which is chronic anemia, and in which that all these patients across the board, in which that they will be on hemodialysis or peritoneal dialysis, and in both conditions they will have chronic anemia and receive an EPO hormone. So the synthetic erythropoietin hormone, which is in a form of like Procret, Epigen, or Procret, they um, I mentioned this in class as well in terms of that the parameters in which one would you given or hold it. It's based on the H&H. So you have to make sure that in the patient's H&H and blood pressure within a range. So the H&H, we're going to adopt these two numbers, the 1230. So once you see that patient's hemoglobin is 12 or over or higher, hematocrit 30 or higher, then you would hold that Procret or Epigen or EPO hormone that day. So it should be held because that's going to result in some adverse effects or side effects or even complications such as the extremely high blood pressure, and that could result in or lead to stroke or CVA. So the other parameter would say that, or maybe the contraindications for this EPO hormone. The contraindications that this EPO or erythropoietin therapy, it's contraindicated in clients or patients who are diagnosed with not all patients with hypertension. I would just limit it to be restricted to the patients with uncontrolled hypertension, patients with malignant hypertension, patients with uncontrolled hypertension, patients with maybe difficult to maintain or treat or control. So in these conditions that you have patients with high blood pressure at all times for any of these of the previous reasons, is that this is not good for them to be on this hormone. We have to find other ways, either to take care of the blood pressure first and then and then anemia, or find out about the other medication that could treat the anemia other than the EPO. So, and we all understand why patients with a chronic anemia or ESRD, end-stage renal disease, they develop the anemia because of the kidneys. One of the functions of the kidneys is the production or secretion of the EPO hormone. So kidneys, when they fail, they are unable to do the job. So the second concept and understanding the management of patients with chronic CKD or ESRD is the phosphate binders. Like silivimir is one of, silivimir hydrochloride comes with different like brand names of Renvela or Renagil and other brand names, because this is critical because patients when with the ESRD, the kidney is unable to excrete the phosphorus. So in that case, these medications are supposed to be given with meals because they reduce the absorption of phosphorus from the intestines. So we know that the adverse or the inverse relationship, between the phosphorus or phosphate and calcium. When we reduce the phosphorus, it will elevate the serum calcium level. So that will decrease the serum phosphorus as well. So again, the phosphorus and the calcium, they inversely related. So the phosphorus, when it's, we know what's, again, when, why patients with ESRD have increased or elevated phosphorus in the blood. So increased plasma phosphorus in the blood in patients with ESRD because kidneys are unable to excrete them. Now the complications of patients with ESRD, end-stage disease, they will be on either hemodialysis or peritoneal dialysis. And I would like just, from the book to read about what would be the criteria for selecting patients to be on hemodialysis versus like peritoneal. And would be a good fit for each one and the complications associated with each type. So the complications, for example, one of the most serious complications with that will be associated with the hemodialysis is the disequilibrium syndrome, in which the patients with this syndrome will, complain of these symptoms listed on this slide, like headache, nausea, vomiting, and restlessness. These may be like these are very common signs of the dialysis disequilibrium syndrome. So why patients develop this syndrome is because of the rapid decrease in fluid and the pulling the bun or the urea from the blood by the dialysis machine. So the rapid decrease in fluid and the bun levels, it can cause cerebral edema. So when we pull the urea fast and the fluid as well from the blood or through dialysis, that's going to result in a cerebral edema in the brain cells, and that will eventually or subsequently is going to increase the ICP, intracranial pressure. Now, other complications or complications of peritoneal dialysis. So peritoneal dialysis,
Professor,
yes.
before, because you were saying for the disequilibrium syndrome, right?
Hmm.
Patients can have ICP, but I was looking for the treatments and I found beside the mannitol, we can give benzodiazepines or anticonvulsants for seizures.
Yeah. So the best, I mean, most of questions around this concept requires that we as RNs, nurses, are to make sure that we have an anticonvulsant medication available in case, because most of the time when we have patients with, hemodialysis, we expect that this to happen, especially on the dialysis side departments, is that to have a PRN or PRN order ready for the patient in case they develop this syndrome. Or you can always call for, PCP to request that kind of medication or order. So the answer, most of the time, the answer is that make sure that you have anticonvulsant medication available. And it's not necessarily to be like the, diazepam or benzodiazepines, but the anticonvulsant medications. And we should have the list of all of them. And I believe the last slide includes some of these medications. And you will also treat patient once they develop this complication, like a bit elevated, so you can decrease or prevent the increased escalation of ICP, and you have make sure that you have an untakeable blood cell medication readily available, um, because we know the sequence of events from the urea removal to the cerebral edema and then to the increased ICP. So that's for hemodialysis and this syndrome. Now, the peritoneal dialysis, one of the most serious complications is the infections, in which that you will find the effluent, which is the dialysate when it's coming out of the from the abdomen or through that catheter. You will see it like cloudy or opaque, um, and it's a sign of peritonitis. And we all know the classic or the most common sign of peritonitis, which is the board-like abdomen, rigid abdomen. However, when you see the dialysate, it becomes like now here's cloudy, but what about when it becomes like brownish kind of color? So the brownish effluent is always a sign of intestinal perforation. The and we went over the concepts of medications. Would you give medications before, during, and after dialysis? We always say after dialysis, and except for certain conditions, and um, we know these specific conditions, such as patient with like extreme high blood pressure, and you are going to send patient to dialysis in like 20 minutes or 30 minutes. We definitely have to give the blood pressure medication. So we have to give them patient's blood pressure is like 160 or 170 over 100 or 110. Definitely you will go on to give the blood pressure medication to the patient before dialysis. But in general, it's a general rule is that we will hold all medications across the board until patient is comes back from dialysis. Um, And for vascular access to hemodialysis, we know that we have different access devices. One of them is going to be the jugular vein or the um subclavian, which is the porticath. That's the temporary one. That's unless that's the only or the last resort that sometimes we have seen like patients with this catheter for the rest of their life or this lifelong or long-term use. But in general, or the good practice is that we will use this porticath or this is subclavian or catheter to be used only temporary use only. So for a couple of days, couple of weeks, until the fistula or graft, or especially fistula nowadays, is mature and readily available, or it's fully mature and ready to be used. So, because we know that the fistula, once you create the fistula, it takes 4 up to sometimes 6 weeks and maybe more for the incision, for the suturing, because we suture the artery and the vein together. So that takes several weeks for the fistula to be fully mature and ready to be used for dialysis. So in the meanwhile, we're going to use the porticath or that catheter, which is the external catheter, to be used for dialysis while waiting for that fistula to be readily available, or I mean, like ready, mature and ready for use for dialysis use. So the now criteria for patients to be diagnosed with ESRD and go to dialysis or undergo dialysis. I would recommend that everyone to go to that acronym, the classification of the renal dysfunction, RIFLE, rifle. And you'll find the each specific classification of this of renal dysfunction and the associated um, urine output, creatinine clearance, and the creatinine levels, and the GFR. Especially if you just focus on two main elements or criteria, the GFR and the urine output. I'm not requiring, asking that you know every and each one of these criteria for each classification within that system. But at least just to have an idea is that when the GFR is severely very low, when it's very low, then you would know that like patients like GFR like 5 or 10 or 15, or that will be a patient with a and stage renal disease. Um, the GFR supposed to be one of the cutoff, also to know what is the cutoff for GFR, because we go by the cutoff, which is 60. As long as our GFR is over 60, we are fine. Our kidneys are able, is functioning within range and healthy. Any number less than 60, it's not good for kidneys to have GFR less than 60. So the cutoff always for healthy kidney is above 60. So dialysis also may cause other um, complications. So patients with on hemodialysis therapy, um, they complain sometimes from the because due to the hypocalcemia of lower extremities, leg cramps, like muscle cramps of the lower extremities. Um, we have to check also assess the a fistula for the Broe and Thrill, B/T, Broe and Thrill, Thrill. So that because this is the indication that the fistula is fully functioning and it's healthy and it's um, I don't ever like I don't know if you have if you have ever like seen the fistula, you will find that the fistula is a raised kind of area or like side of the skin is kind of overgrowth of the skin and the fascia, so you'll feel like a raised kind of side or spot on this on forearm on the the upper arm or lower extremities sometimes, and it's like a pumpy area, and this pumpy area is going to be you can feel it, and you can also listen to the Broe with your stethoscope. So listening to this with a stethoscope to the Broe and feeling the vibration and the kind of the turbulence of blood underneath or like under your when you palpate the area, that is both indications or both results on both findings is positive or are positive, both positive for a healthy functioning fistula, positive Broe and positive Thrill. Anytime you're unable to get these positive results or unable to assess or find, or hear or feel or palpate, and you feel nothing, you hear nothing, then that's a negative findings. These negative findings is going to result in that we always going to reach out to the PCP and call them up. So you have to call the PCP and let them know that the fistula probably is not is blocked or clotted, something wrong with it, and we have to do something about it. Otherwise, patient cannot do. We won't be able to do the dialysis. In the meanwhile, if that's the case, is that they have to create a new one, and this is like permanently um, became dysfunctional and won't be used or cannot be used. So if we cannot use it for good, is then we have to create a new one. Creating a new one requires that patient also supposed to get a subclavian or like one of these portacath catheters um, for temporary use until the new fistula is being created and mature. And that takes again and again, that we will go back to that several weeks until it's mature. So the hyperkalemia is a common complication of acute kidney disease. So patients with renal dysfunction, CKD, ESRD, they develop hyperkalemia. So potassium level elevates, and the treatment, there's a sheet on also I posted in Canvas about the treatment of patient, for patients with hyperkalemia and the three levels or stages or levels of hyperkalemia and how would you treat hyperkalemia. So it's life-threatening if immediate action isn't taken to reverse it. We have to reverse the hyperkalemia by one of the three levels, and I would encourage that you go to that sheet or it's like I think the one a page or page and a half explaining about the three levels of management and for patients with three stages of or levels of hyperkalemia. So what would be like, the lowest, like minimal, moderate, and then severe hyperkalemia. For each one, there is specific like in the treatment and therapy and management for each one. So the because for example, sometimes we administer like glucose and regular and insulin, regular insulin infused like IV infusion with the sodium bicarb. Others would get like calcium gluconate. So you will read about, it's very important, document to go to refer to about the treatment of patients with hyperkalemia. So you'll find it on Canvas. Now, patients with ESRD renal dysfunction and risk for bone fractures. The why they develop or the rationale behind the bone fractures in patients with ESRD because of the decrease in the bone mineral density described as the osteopenia. In other words, that osteopenia, which is a stage that precedes the osteoporosis. Remember that this patient with ESRD, all these kind of like electrolyte imbalances, they develop hyperkalemia, hyperphosphatemia, hypocalcemia. So the hypocalcemia, it's a significant factor that may contribute to this bone fracture. In other words, white bone fractures, it's just because patients' bones are not, they're fragile, they're not solid, or they're not like, dense. So and again, on the number two, the hypocalcemia has to do not just because of the hyperphosphatemia and then hypocalcemia, but also another factor that may predispose these patients to develop hypocalcemia is because of the other factor for hypocalcemia. So number one, because of the hyperphosphatemia, patient develop hypocalcemia. Number two is that the kidneys, they activate vitamin D. Part of the vitamin D activation takes place in the kidneys because the activation of vitamin D in the kidneys create the hypovitaminosis D, which will that will impair the absorption of calcium from the GI tract. Because remember that we need vitamin D for the absorption of calcium. So the decreased one more issue or health problem that that may result from this decreased absorption of calcium and the decreased activation of vitamin D and then eventually hypocalcemia is that the calcium when remember in the endocrine system, we'll cover this in in a couple of weeks, is that there is a PTH hormone, parathyroid hormone. And the parathyroid hormone, what would increase the secretion of this hormone is the hypocalcemia. So the triggering factor for the PTH hormone production is the hypocalcemia. When the calcium level drops less than like 9 or 8 or 9.5, so hypocalcemia triggers or result in an increased PTH hormone. So when the PTH parathyroid hormone production increases, that will result in what is called the secondary hypoparathyroidism. So that's another complication that may, result from this hypocalcemia in patients with ESRD. So it's secondary hypoparathyroidism. So associated with another like concept associated with the bone fractures and hypocalcemia as and and eventually may patients this requires an effective and good management of this osteopenia to prevent the development of the osteoporosis of patient to develop this to get into advanced because advanced osteopenia lead to osteoporosis. Is that this patient will be on? So patients with ESRD, we recommend that we prescribe them a biphosphonate medication like alendronate Fosamax, and it comes in two dosages like 35 milligrams and 70 milligrams. And we also recommend that every that you go review the nursing management when you take care of patients on this medication, like nursing care of patients on biphosphonate medication. Can be alendronate, Fosamax, or have a list of 4 of them. For all of them, they have a suffix dronate. Alendronate, one of them. Dronate is a suffix for the 4 medications under the classification of biphosphonate medications. So there are specific, nursing care of patients on this group of or class of medications. Okay, food high in phosphorus. Also another might be a little challenging, for some to identify the food or different types of if you have, these type of questions are really to some extent challenging because you have to find out if this type of meat or food or in its high in phosphorus or not. So I can list some or few things to indicate about the high phosphorus or food high in phosphorus. So because kidney fails to excrete the phosphorus, so it will result in hyperphosphatemia. So in this case, that we have to restrict the phosphorus containing foods. So food that is high in phosphorus supposed to be restricted in patients with end-stage renal disease on hemodialysis. So you'll find a long list of food products that are high in phosphorus. So we have to restrict phosphorus containing foods. So I would encourage that you go to the book and find out about, this type of, food that is high in phosphorus, such as beans, legumes, nuts, especially the peanut butter, one of them. So food that is, most of the nuts are full of phosphorus. Legumes are same thing, high in phosphorus. So try to restrict that in the diet of patients on hemodialysis with end-stage renal disease. Another complication that may result from or in patients with ESRD on dialysis, that the pericarditis, and the pericarditis, which may occur in clients with this disease, and if not treated, the inflammation can lead to or advance and progress into a pericardial effusion. And then the next step is cardiac tamponade or tamponade. The cardiac tamponade, which is we cover this under cabbage, which is a fluid around or secretions or pressure around the heart and the mediastinal space. That's going to restrict the cardiac filling phase and emptying. So it will be like assess, restricting the cardiac function, and that sometimes it may lead to death. So the pericarditis, again, it can lead to, which is inflammation, that can lead to the pericardial effusion, cardiac tamponade, and then death. The manifestations would may include manifestations of pericarditis, severe chest pain, increased pulse, so tachycardia, SOB, shortness of breath, and if the patient progressed into a cardiac tamponade, that requires so patients with tamponade, now we have to remove the pericardial fluid by replacement of a needle, catheter drainage, like the placement of a needle catheter, or and when which that we are going to remove that fluid manually. So the removal of that fluid or drainage tube to be inserted into the pericardium to remove the secretions and fluid and treat that cardiac tamponade. Okay, so transplantation or transplant rejection, that's another topic that I would recommend that you review it from the book about the manifestations of rejection, and also the medications. I listed the meds in the last slide, the immunosuppressant medications, the immunosuppressant drugs. And nursing care patients on immunosuppressant medications. So that's all about the kidneys and renal. It's basically the ESRD and CKD and the management of patients with interstitial disease. Now, the neuro, we started with Alzheimer's is just a review. So we'll start with Parkinson's disease. So we went over the pathophysiology in class and the manifestations, and one of the most serious or like the swallowing difficulty associated with Parkinson's disease. And what I've seen is that students most of the time they assume that, or they kind of part of assumptions that all patients with Parkinson's disease, they will have that swallowing difficulty to the point that they should be on thickened liquids. Thickened liquids is supposed to be a management or a step taken within the plan of care based on the given scenario. So you should be provided some type of hints or indications, or some information within the stem of the question if the patient requires that can swallow thin or thickened liquids. So we don't assume that all patients with swallowing difficulties, including the Parkinson's disease and other diseases, that they should be on thickened liquids. Thickened liquids or thickened liquids supposed to be prescribed by the SLP, speech language pathologist, who would do the following: evaluation of the patient's swallowing ability, they will do the following evaluation. Either they can do the bedside, they can do the, barium swallow, there are different ways of doing that. So based on that evaluation of the clinical plus the diagnostic, that would result in that the SLP would say they will give us like specific plan and directions and the consistency of both liquid and solid food. So it's not an assumption that we cannot use just to get liquids because we think the patient is like having difficult swallowing. We're supposed to have a specific directions and orders from the SLP has been approved and also been like supposed like been approved by the PCP. So the order should be clear and the chart to state that patient should like sit up like 90 degrees or up head a bit elevated when they will have specific guidelines and directions of how to feed the patient and the consistency of foods, the consistency of liquid and solid food, the directions what should be followed or done by the nurse, by CNA, but by the RN. So, and the point here I'm trying to get is that do not assume that all patients with swallowing difficulties, they're always supposed to be in thicker liquids unless it's provided, given within the stem of the question, is that patient supposed to be on thicker liquids? So the thicker liquids, we're going to adopt only two consistencies, the thin, either the honey or nectar thick, honey thick or nectar thick consistency. And the solid, it depends on that, finger food, mechanical soft, but the most important thing about the liquid, the thin liquids, is that thin liquids, like it's not thickened. When it's thickened, is that the nectar thick or honey thick, but both will, go under the thickened liquids. Now, we all know that, patients, they do not like the thickened liquids because their consistency is not thin, the normal kind of like, natural, normal, like, consistency of liquid form. So that's why they're, usually being disliked by all patients across the board. So now back to that was, I think, the point I kind of refer over the years. I've seen like, students, they think that, difficult swallowing equal thickened liquids. No, it's not always the case. It depends if that should be, so should be, so this specific level of consistency to be in thicker liquids supposed to be determined by the SLP, speech language pathologist, and has been approved by the PCP, and they will provide us with the specific plan, guidelines, and directions on how to feed the patient, to set up the patient, to set up the tray, small bites and consistency of liquids, consistency of solid food, and so on. So this is like a full plan. Do not assume this full plan unless it's given or mentioned in the stem of the question. Next point is read about the levodopa as one of the medications also and major or main meds to be prescribed for patients with Parkinson's disease, in which the patients with so levodopa, it's usually or cinnamate with carbidopa. We explained also in class. Why would you add the carbidopa, the levodopa? So that will decrease the muscle rigidity, and it will eliminate. It will also reduce and take care of other manifestations associated with Parkinson's disease. The questions that has to do with which of the following patients you would assess first, for example. Which of the following patients you would like, intervene or, prioritize in terms of interventions or assessment or evaluation. The anticipated manifestations of a disease process or specific disease, it should be always excluded. Do not include or do not select that patient to be the one, like let's say, for example, like patients with Parkinson's disease, with patient presented with Parkinson's disease presented with mask-like face, drooling, excess perspiration. These are common manifestations of Parkinson's disease. So that should be always excluded. And questions like that. So questions in terms of that, you should always exclude the patient with anticipated manifestations. That should be always excluded from these type of questions. Which of the following, patients you would assess first, would intervene first, would evaluate first. So prioritization, exclude these kind of patients with anticipated manifestations that are associated with that specific disease. Any questions so far?
No, thank you.
Okay, epilepsy. Epilepsy, which is there are different types of epilepsy. Um, the the most common one, which is the tonic-clonic, which is the grand mal seizures, in which that patient would have a deep, like a state of deep relaxation and then contraction and then breathing, like cessation during the contractions or the spasms. Um, and during this period, patient may become conscious. And we went over this like in class. We covered all of this stuff. We said that the patient become confused, disoriented, and post. So remember that we said pre-ictal and then post-ictal. So the pre-ictal, which is the aura or prodroma. The aura, which is pre-ictal, which is the epilepsy activity or seizure activity. Sorry, the seizure activity. And before that, we have patient may experience aura or prodroma. You may read, can read about that. The difference between them, there's like a nice table, provide like a description of each one. And then ictal, which is the seizure activity. And then the post after the seizure, which is post-ictal. So when you see these kind of terms and the, questions, you would know that post-ictal means after the seizure activity. So the post-ictal, it depends on the time. Most of the time, patients would go to deep sleep. They would relax, or they um, uh, they become semi like unconscious, or I'm sorry, they regain consciousness. So the most important concept here is status epilepticus, which is a state of continuous when the patient develops, seizure in activity within that lasts for, a few seconds, a minute or two, or that is short, expected epileptic um, um, or seizure like activity. So the state of continuous seizure activity or condition in which seizures recur in rapid succession without return to consciousness between seizures. So patients having like recurrent seizure activities or seizure session, like seizures with rapidly one after the other in rapid succession without return to the conscious consciousness between the seizures. So patient can go from one to another seizure one after the other. So the continuous seizure activities one after the other, so it's a series of activities um, connected together as one continuous seizure activity that is status epilepticus. So that's the most serious complication of seizures, of epilepsy, and it's it's called a neurologic emergency. So status epilepticus can occur due to any type of seizures. So any type of seizures can lead to the status epilepticus. So we would like to I would encourage that you go to read about the status epilepticus, what would be the appropriate supplies to be readily available for that patient if that's like a hospital setting, like some sectioning supposed to be there, safety precautions, and also medications, and treatment for that would be the benzodiazepines. So the Valium IV, that would be the most appropriate, like the most effective one. Um, Meningitis. We went over the clinical. There was presentation about meningitis, and the presenters, they went over the manifestations, the pathophysiology, manifestations, therapeutic management, manifest or signs of meningitis, and the CSF analysis, and how CSF analysis can be used to differentiate between the viral from bacterial meningitis, and this table explains it very well as a comparison between bacterial and viral meningitis. The most important nursing intervention for clients with meningitis is the accurate monitoring and recording of their neurologic status. We have to monitor the patient's neurologic status, continuous monitoring of the neurologic status. And also the precautions required for the when we take care of a patient with meningitis. What type of precautions should be used for this specific condition? Now, spinal cord injuries, one of the most basic, I would say, basic concepts in taking care of patients with a trauma is the log roll technique when transferring patients with suspected spinal trauma. So, and we went over also in class difference between two different types of shocks. And one of them was the spinal shock. And so the signs symptoms of a spinal shock and the different levels of spinal cord injuries, that's cervical, thoracic, lumbar, sacral, the and the expected neurological deficit that may result from or result after the injury, and how to transport client with suspected cervical and other levels of neurological injury. So it's always safe transfer of patients status post suspected spinal cord injuries. Then the most important also medication to be reviewed here is that steroids, methylprednisolone, and others. Because the initial impact, we understand the pathophysiology of the initial impact or the primary impact on the spinal cord from the trauma. But within 24 hours, 48 hours, or even within the first 24 hours, there will be manifestations of a secondary injury from the inflammatory process that would take place around the spinal cord. And is going to result in inflammation, inflammatory manifestations, in edema and swelling that's going to press against the cord. So that will result in a secondary injury. And that's why there is always a protocol in trauma centers is to give the steroid or other medications similar to the steroid to prevent secondary injury. Because sometimes secondary injury can be detrimental, can be like, more harmful than the initial impact or initial injury. So the second concept here is the autonomic reflexia, in which I know that the pathophysiology is quite complex and difficult to even to go over the all different seven or more points, because there is one of the figures that starts from the triggering factors up to the all the pathophysiology kind of explained that way in that figure. But the autonomic dysreflexia, the most important for mid-surge here, for mid-surge adult L3, is that would like beyond the pathophysiology. The management, so the most important is the management of patients with spinal cord injuries so we can prevent the autonomic dysreflexia. And we said that there are other names of this autonomic dysreflexia. Hyperreflexia is another name. So to identify the precipitating factors, the triggering factors that are going to trigger this complication. There are too many factors that may trigger this or precipitate this complication. One, this autonomic dysreflexia. So first of all, I would like to just review the manifestations of patients with dysreflexia, as you would be able to identify the complication when it develops. Second, um, before the manifestations, we would like to identify the factors so we can prevent the factors, so we can take care of these factors not to happen. So prevention is the key for autonomic dysreflexia. Understanding that the precipitating factors for dysreflexia can be the full bladder. So that's why we always are going to palpate the pubic area for bladder fullness. Remember, these patients, most of the time, they are paraplegic or quadriplegic. Second, we're going to check for any catheter, like polycatheter, or if there's a polycatheter, most of the time there is a polycatheter. If there is any occlusion, blockage, that is assessed for, signs of urine retention. Also, if the patient is being constipated, if there's an fecal impaction. So these are the most common factors that may precipitate the patients to develop the autonomic dysreflexia. The medication that is most effective to treat, once you have identified this patient has been developed dysreflexia, you'll find patient will be on or prescribe, the PCP would prescribe the hydralazine. Hydralazine, eprizolone. It's an antihypertensive drug medication, but it's very effective to treat that extremely high blood pressure in patients with autonomic dysreflexia. Now, treatment of patients with spinal cord injuries, there are other complications that may result or develop from the spinal cord injuries other than this dysreflexia. But the most important thing here is that the concept of rehabilitation, the concept of rehab of clients with spinal cord injuries, it always starts from day one when they are admitted to the hospital. So we have to start planning and start the plan of care for rehab of that client from day one admission, being admitted to the hospital. So the baclofen, which is a muscle relaxant, Laricel, it's a muscle relaxant. The baclofen has you're going to review also the diagnosis of the side effects, some mechanism of action, nursing care of patients on baclofen, nursing applications, and so forth. You will also find that the most common side effects of the baclofen, so spasticity may lead to, oh, I mean, sorry, it may result from the baclofen sometimes, or muscle rigidity from the baclofen. We know that it's muscle relaxant, but sometimes it's like counter effect from baclofen. Tinnitus also is a baclofen, but these are, I would say, it's not like common with a therapeutic dose. Sometimes patients they will like overdose or too much of this drug. So it's most of probably is going to be here is the signs and symptoms of baclofen toxicity more than just the baclofen side effects. So baclofen toxicity, patient dose is supposed to be decreased, or patients taking too much of the drug, overdose. So this baclofen toxicity is going to result in exaggerated spasticity, muscle rigidity, tinnitus. These are signs, adverse effects of baclofen, and most of the time it's due to the from overdose. Okay, MS.
Professor, I'm sorry. Was
Yes.
the baclofen for the autonomic dysreflexia or for spinal cord injury?
No. Baclofen is not for dyspraxia. The dyspraxia, the most concerning manifestation is extremely high blood pressure. But baclofen is more drug is just muscle relaxant.
Okay.
It's a muscle relaxant that can be prescribed for different neurologic disorders like spinal cord injuries. It can be given to any other neurologic disease, especially when there is a muscle spasm or muscle rigidity. Um, so the multiple sclerosis would like also to review the pathophysiology, the clinical manifestations, the treatment. There are not too many medications for multiple sclerosis, but there's only Copaxone, one of them. It's also listed on the last slide under the list of medications to review. So when the patient develop an exacerbation of multiple sclerosis, it's due to some stressors. Like there are some factors that may trigger, like it's progressive disease, and it's patient will um, live through or go through the exacerbations and remissions of the disease process. So there are some factors that may precipitate the exacerbation of the of the MS. So this exacerbation of the MS can result from excessive exertion, overheating, sometimes infections. These are the common stressors that can or may precipitate the exacerbation of the MS. We will attempt in terms of the independence as a general concept or an important concept in the management of patients with MS is that clients should be encouraged to live as independently and normally as possible, but should be plan to be readily available or developed to reduce fatigue and conserve energy. So as you know, it's most of the time patients with MS, they live in their own independent, right? Home setting or nursing home setting. So they will be on their own for the most part. So we have to encourage them to live as independent and with a fair and normal life as possible. But there are always a plan to teach them how to reduce fatigue, how to conserve energy. That's very important for patients with MS. And for ALS, I believe we went over this in class. We covered a good deal of the ALS in terms of manifestations and treatment. There's only one medication, that would delay the progression of disease process in ALS, which is Rilotec. Only one drug for ALS. And we said that, the ALS doesn't affect the intellectual ability. It's mostly going to, affect the motor function only.
Wait, Professor, what did you say
Yes.
about medication for ALS?
It's the last medication. Sorry, right here. Rilotec. Yeah, that's a drug for ALS. And GBS, I think this disease it's not fully understood in terms of that, even the pathophysiology, the etiology, especially the etiology and the triggering factors, and what would make the patient develop this, this disease. And so what they found, there are some risk factors has been identified and listed, or identified risk factors such as like patients. I have a list. I think that we went over this in class. One of them is the history of acute illness, especially viral infections. That would be one of the risk factors to develop the GBS, Guillain-Barré syndrome. Can be trauma, surgery, or patients who had received immunizations 1 to 3 weeks before the onset of the neurologic symptoms. So there is a table, I believe there are in the PowerPoint slides that list all these triggering factors or the risk factors, including this, like acute illness, trauma, surgery, immunizations, vaccines. Now, because the nature of the disease process here is that, or the pathophysiology of this disease, of the GBS, there are different forms, different patterns of disease. One of them, or the most common one, is the ascending form, is that the weakness and paralysis starts from down up, from the feet, and extends to the upper part of the body until it reaches the lungs, in which that at this point the patient will be in the ICU under mechanical ventilation. So the treatment for this disease, what they found, and they believe that this is an autoimmune disease that, and there is antibodies that are going to attack the nervous system. The plasmapheresis, they found that great effectiveness post plasmapheresis sessions in patients with GBS. So patients with GBS, when they undergo the plasmapheresis, which is like filtering the blood, similar to the, like an idea of hemodialysis. Hemodialysis, we kind of clear and we remove all the waste products and urea and other stuff from the waste products from the blood. Here we are going to remove all the proteins, like especially the fragments or the globulins or the antibodies from the blood. So the removal so that's called plasmapheresis. So one of the major complications that patient develop hypovolemia. So we have to be proactive and make sure that we hydrate the patient to the point that patient is not going to result or develop hypovolemia. So that's one of the major risk factors is hypovolemia, and try our best not to prevent it. So post plasmapheresis, we should monitor the patient's fluid status, assess patients' vital signs, because that could provide some indications of hypovolemia. And the most important thing is that to administer the fluid, replacement as indicated to prevent the hypovolemia. That's about plasmapheresis. Now, another topic we went over is MG, which is a very important topic. Because the other day, last week, I believe we had a patient with MG, myasthenic gravis, and it was really typical to what we have seen or read in the textbook. It was really typical to, in terms of patients like that, diagnostic tests and manifestations, missions on medications taken or prescribed for that patient was very classic or typical to the what we have read in the textbook. So beyond or we went over the pathophysiology, everything, management. So I'm going just to highlight a few things here about the tensilon test. Tensilon, which is hydroconium chloride, it's a medication that belongs to the same group of medications like prostigmine or neostigmine or physostigmine, which is the most effective drug prescribed to patients with MG. And we wouldn't, and the pathophysiologist said that, we would like to increase the acetylcholine at the junction so that the muscle would have a normal function, like normal within range, like, function and normal contraction. So the absence of this acetylcholine at the junction result in general weakness, ptosis, and other MG manifestations. The tensilon test, even though it's a medication from the same list or from the same classification of CHEI, which is cholinesterase enzyme inhibitor or cholinesterase inhibitors, like physostigmine, prostigmine, but it's usually prescribed for testing purposes only. And because this class of medication of cholinesterase inhibitors, they have a very short half-life. So patient will be on let's just say physostigmine, 60 milligrams, will be at least on this medication or within 24 hours, 6 times a day, given the short half-life. Now, this medication, tensilon, it has a ultra short half-life, ultra short. Ultra short means is that the drug, the ultimate, the maximum length of effectiveness will not last more than 4 to 5 minutes. You can see results of improvement when you give it to the patient within like 30 seconds, even within a minute. You will see after injecting this drug to the patient, you will see significant improvement on patients talking, like speaking, patients like swallowing, patient vision, everything is corrected, like everything is back to normal, and improvement will be seen instant within like a minute or less or more. But the improvement, this marked improvement in muscle tone, will not last more than 4 to 5 minutes, given the ultra short half-life, half-life. So the tensilon test, that's why even though that this medication is listed under the CHEI, cholinesterase inhibitors, but it's still, this medication is an ultra short. That's why we don't usually prescribe it for treatment. It's only used for testing purposes only. Now, how do we use it for testing purposes? We can use it for diagnostic, like I'm sure that we know that we have other diagnostic testing, but it's just I would like to highlight how tensilon test can be prescribed or can be used for testing purposes. First, you can use it for initial diagnoses. You can patient presented with manifestations and you want to like rule out or myasthenia gravis, you can give tensilon test and find out. Or patient being diagnosed with myasthenia gravis and patient presented to the ER, and we don't know if the patient had developed a myasthenic crisis versus cholinergic crisis. And I went over this in class about the difference between and compare between these two crises. And if the patient presented with, because remember that we went over the manifestations and we said that manifestations are very similar for the most part between these two crises. And when we give the tensilon test to a patient who we unsure if the patient had developed cholinergic myasthenic versus cholinergic. Now, if the patient after receiving the tensilon test will show a significant improvement in muscle tone, we just described earlier about swallowing, speaking, vision, or generalized weakness and all of that. So significant improvement in all this on the muscle tone, it indicates that this patient had developed a cholinergic crisis. What do you think? Cholinergic or myasthenic crisis? Myasthenic or cholinergic crisis?
Cholinergic crisis.
Remember that cholinergic crisis, if the patient, remember, if they develop cholinergic crisis, then the antidote for that would be to treat them with anticholinergic, means atropine. Patient who had developed myasthenic crisis, myasthenic means under-medicated, cholinergic over-medication. Myasthenic under-medication. So myasthenic under medication. So that's another, I think on my clinical group, we went over this and learned one of the new, or maybe we came up with mnemonic, and we said myasthenic crises under medication, cholinergic crises over medication. So I would encourage, because this is, I know, one of the most confusing concepts in MG. Myasthenic crisis patients develop myasthenic symptoms because they are under-medicated. So when we inject the tensilon test and patient symptoms significantly improve, obviously this patient hasn't taken the drug for a long time or taking the wrong dose, like less than required or prescribed. Patient is non-compliant with medications or with diet therapy, so that this patient developed a myasthenic crisis from the under medication. So I would encourage that you write down MU, myasthenic crisis under medication. That's one mnemonic. MU, myasthenic crisis under medication, patient non-compliant with drug medications, with therapeutic management. With tensilon test, it will result in that patient will show a significant improvement in muscle tone. On the other side, patient who has taken a lot of that medication, overdose, patients taking double the dose every day. So that will be it, or large doses. So that will be overdose, over medication. And that's a cholinergic crisis. So I would encourage that you I'll write down MUCO. The MU for myasthenic crisis, U under medication. So M goes with U, and the C, cholinergic crisis, it goes with O, over medication, overdose. Make sense? So you can clear this kind of confusion of myasthenic versus cholinergic if you remember this mnemonic. M goes with U and C will go with O. Okay?
Okay, Professor.
So because the myasthenic crises, it's an under medication, MU, then the treatment for this patient who we have tested and found from the tensilon test that it's a myasthenic crisis, then we're going to treat this patient with CHEI, cholinesterase enzyme inhibitor, like prostigmine, physostigmine, and I listed the drug on the last slide here. CHE inhibitors, CHEI, cholinesterase enzyme inhibitors, prostigmine, one of them, or physostigmine, or you kind of, I would encourage that you review this medication or the class of meds for MG.
Professor, I have a question.
Yes.
So if a patient has myasthenic crises,
hmm
then prostigmine and pyrostigmine.
hmm Yeah. I'm sorry, Krisha, you said the treatment for myasthenic crisis?
Yeah.
Yeah. So for
Okay.
the patient with myasthenic crisis, because they are, remember that MU, myasthenic crisis, under medication. So we're going to definitely give them, this class, right? The prostigmine, physostigmine, prostigmine. So then on the other side, if the patients you have, because you are going to use the tensilon test, right? Because patient will present it with like myasthenic crisis and cholinergic crisis is most of the time is difficult to differentiate between from the manifestations. There are
Right.
some, distinctions in terms of manifestations that are like, that come in, you can distinctive to each one or specific to each one to distinct them. But to differentiate between these two conditions, but or complications. But most of the time, it's like they are presented pretty much the same manifestations. So that's why tensilon test will be prescribed or given, administered. So when you administer the tensilon test and you see significant improvement, you would know that this is a myasthenic crisis. However, if the patient, you give that tensilon test and then you find that the symptoms intensifies, it makes the symptoms worse, then that's a cholinergic crisis. Then the treatment is going to be anticholinergic drug, atropine. And also another concept that goes with the MG and the cholinesterase enzyme inhibitors like prostigmine, stigmine, or physostigmine is that the drug promotes muscle function in class with MG. So when we administer the drug on a daily dosage, daily basis, like in the plan of care of patients with MG, they're on their own, dependent most of the time, or nursing home, taken care of, by nurses. But for the most part, is that the most important aspect of this, or the concept behind this, is that, and I highlighted this also in class about the clients with MG on these medications, given the short half-life and the effectiveness, and we have to. So the point here is that it should be timed with anticipation of activity. And this concept explain you can provide several examples of or application example. Has to do with swallowing, has to do with time, meal time, or time to provide meals or to offer their meals, time to, for activities like outside, like outdoor activities, activities like, social activities, holiday activities and others. So you have like too many examples of application examples of how would you time the drug administration with anticipation of activity to be very close to the activity being anticipated by the patient or to be taken care by, to be taken care of, by patient or, caregivers. So this is kind of concept, and think if you type it, like, if you search, like, research it in different, like, textbooks or mid-search textbooks, you'll find like good examples of application, like, examples on how would you apply this concept in terms of drug timing or medication timing with anticipation of patient activity. Now, I don't have any specific, like, knowledge. I mean, we went over the trigeminal neuralgia and Bell's palsy. The medications listed on the back here, I mean, the last slide, on this slide. And again, if you just refer to my, to the class notes or about the trigeminal neuralgia and the Bell's palsy. Like, for example, if we look at that trigeminal neuralgia, the TN, trigeminal neuralgia, the oral hygiene is sometimes neglected in clients with this disease, because sometimes they are afraid to and frightened, or they have some type of, like, fear of triggering the facial pain, because that could result in, like, trigger the facial pain and lead to the gum disease, dental cavities or abscess, or so we kind of encourage them to maintain the oral hygiene with some care, I would say, like, when the client clench their, like, facial muscles, that could result in a painful sensation. So they can be, like, more gentle when they clean their mouth, or, I mean, like, their teeth, or so. Oral hygiene is important, but with the minimal a clenching of the mouth, or with minimal, like, muscle spasm, I would say, like muscle contraction. We try to avoid the palpation, because sometimes the light or even touch of the the facial, the affected side, palpation may be triggered. Sometimes it will, it may trigger the pain, and that should be avoided. Now, that's in trigeminal neuralgia. And Bell's palsy, because Bell's palsy results in a paralysis of the eyelid and loss of, because they cannot blink, the blink reflex is gone of the affected side. The and we said there are, patients aren't able to do like three things, right? So the these problems, they render the eye susceptible to drying, because they unable to close close the eyelid. So that will keep the, like, in the retina, I mean, the retina, yeah, the retina is open to dryness, or to get dry. So to prevent the retinal dryness, to use moisture, like, eye drops. We can also cover them, and if need be, so we can prevent the dust, debris, dust, and irritation, dryness. So sometimes covering the eye is important at some point. So because the patient unable to close the eye, so they don't or they don't unable to close the eye. So the sorry, I said the retina, it's the cornea. Sorry, I meant the cornea. So the corneal irritation, corneal the dust and debris and irritation to the cornea or gets into the cornea and cause these kind of irritation and infection. So at some point, even it may result in ulcerations, abrasions of the cornea. So protection of the cornea is the key element of the management for patients with Bell's palsy. So sometimes we will teach them to manually close the eyelid at intervals, every 10, 15 minutes to close the eyelid. Because they're able to do that, their own voluntary. Involuntary. So they will be doing that, to kind of close the eyelid with their, manual. So that will protect the cornea from all the previous things that we have mentioned: the dryness, irritation, dust, and debris. And sometimes we have to instill artificial tears during the day, 4 up to sometimes even 6 times a day, to prevent that these problems from happening to the cornea. That's for Bell's palsy. That's one of the concepts that goes with Bell's palsy in terms of treating the patients with this disease. And the last one is the last slide, which is the list of all medications. If not all of them, if there's anything additional meds, I'm going to share it with you. So let me, if you have any questions. I'm going to stop recording.